Afternoon and welcome to the ESMO Guideline Real World Cases webinar. It's my pleasure to invite you, and this is one of the 6 of new series of ESMO Guideline webinar, and the topic of today is localized colon cancer. I'm Erika Martinelli. I'm Associate Professor in Medical Oncology at the Department of Precision Medicine at University of Naples, and here I'm served as a subject editor for the ESMO Guidelines for GI tract. Today, I'm happy to share this webinar with the distinguished panel of experts. You see, I will present later on during the talk. And of course, we have a learning objective for this webinar. The first, of course, is to promote the evidence-based quality of cancer case by disseminating the ESMO clinical practice guidelines through the oncology community. The basis of this webinar is focused on a clinical presentation of cases, and the one of today will be on localized colon cancer. And we have also a critical review of the ESMO practice guidelines. And finally, a discussion how we can implement the guideline in our clinical practice. So this is the agenda of today. After a brief introduction by myself, there will be a cases by Dr. Cardone, who is one of the young oncology member of the oncology working group. We have also a presentation from Professor Tayeb, who is one of the authors of the localized colon cancer guidelines of the ESMO. And there will be a final consideration from Dr. Lipositz, who is one of the participant oncology working group member. And after this presentation, we will have 10 minutes in which we receive the question from you, from the audience, and we will be able and we'll be happy to reply to your questions. These are my disclosure slides. So just a brief introduction on the topic. Colorectal cancer is the third most common in men after prostate cancer and lung cancer, and is the second, according to the incidence, after breast cancer. Colorectal cancer is the fourth most common cancer-related causes of death globally, but we can say that mortality, especially in Europe, is decreasing. And this may reflect the implementation of the new treatment and the new insight that we have for the treatment of this disease. The estimated number of new cases from 2020 to 24 will increase of 27%. You see that is more common in the so-called economically developed country because it reflects the risk factor of sporadic cancer. We know that lifestyle and behavior characteristics may impact on the etiology of early colorectal cancer. Obesity, physical inactivity, alcohol intake, smoking cigarettes, and especially high red meat intake may have an impact on the development of this cancer. We have also some unchangeable factors like the age. In fact, the 70% of patients with colorectal cancer are more than 65 years of age. We have some medical history of disease like adenoma, which is a precancerous lesion. And we know that from adenoma, after acquiring a mutation in important pathway like APC, KRAS, and with pattern, we may have the transformation and transition to adenocarcinoma. There is some inflammatory bowel disease that may increase the risk to develop colorectal cancer, like Crohn's disease and ulcerative colitis. And in 2-5% of colorectal cancer are related to inherited syndrome like familial adenomatosus polyposis coli, that is caused by a mutation in the APC genes. And another syndrome like called the Lynch syndrome or hereditary non-polyposis colon cancer, which is caused by the mutation in the gene that controls the repair of DNA. So for this high-risk population, the screening, of course, is mandatory, and also is mandatory also to perform the genetic counseling. But the screening should also be performed in average risk population around 50 of age, with some non-invasive tests like fetal occult blood test, or with some invasive tests like colonoscopy. So, of course, surgery it's the cornerstone of the treatment of early colorectal cancer. And of course, laparoscopic colectomy should be performed if technically expertise is available, of course, because it reduces the mortality and reduce also the days of hospitalization. But after surgery, it's very important to have a pathological report with all the information that are listed here. We should obtain the description of the morphological specimen. We should know which kind of procedure has been carried out. We should know also the sites of the tumor, the presence of perforation. We should know if there is an histological type that is more aggressive, like mucinous cancer, the grading of tumor, the extension of the tumor into the bowel wall, the T stage, the involvement of rocoregional lymph nodes, the N stage, the presence of the absence of tumor deposit, the presence of the absence of lymphovascular or perineural invasion. And finally, it's very important to set and to have also information about mismatch repair or macrosatellite stability status of the tumor. For early colorectal cancer, is not mandatory to have information also on RAS, on BRAF, or HER2, which are markers that we use for treatment decision in metastatic setting. It's very important to obtain all this information because we have to set the recurrent risk, because we have to calculate the benefit that a patient may derive from adjuvant treatment. The role of adjuvant treatment is well described for stage 2 disease when there is the involvement of the lymph node. But the benefit is lesser in stage 2. In fact, in stage 2, we ask for more markers, more parameters in order to assess the risk of recurrence. We have major prognostic parameters like the number of lymph nodes that should be more than 12. The T stage, the T4 stage, including perforation, also is very important to know. And we need to know also this information in order to determine the minor prognostic parameters like high-grade tumor, the vascular, lymphatic, and perineural invasion, the level of the tumor marker, the SIA, before surgery, and the tumor presentation with obstruction. And of course, besides these clinical parameters, we need to know for stage 2 colorectal cancer the status of MSI MMR. So after having all this information, it's important to offer to our patient an adjuvant postoperative treatment which reduces the risk of recurrence and of course reduce the mortality for this cancer. We know that according to the algorithms that are present on the ESMO guidelines, there is quite different in low and high risk patient according to the duration of treatment. The drugs that are used are the combination of fluorouracil with the oxaliplatin. And for stage 2, we also assess the risk of the patient. And in some cases, we may offer a combination of 5-FU with oxaliplatin or 5-FU or capecitabine alone. But I don't want to go further in detail because we need to move on in the webinar. And it's my pleasure to introduce Dr. Cardone for the clinical presentation.
So thank you, Professor Martinelli, for your kind introduction, and I thank ESMO for the invitation to join this real-world case webinar on localized colon cancer. My name is Claudia Cardone, and I am a consultant medical oncologist at GI Unit at National Cancer Institute Pascale Foundation in Napoli. These are my disclosure. I would like to present you the case of a patient, a male, 64 years old, Caucasian, office worker. In May 2020, he suffered from abdominal pain, he had change in bowel habits, and he had a positive fecal occult blood test. His medical history presented a mild hypertension in treatment, He was a smoker, 27 pack years, and he had no allergies. His family history was positive, with maternal aunt diagnosed with localized left-sided colorectal cancer when she was 55 years old. In June 2020, he had a pancreatoscopy, a complete exam until the cecum, and a left-sided colon lesion was found bleeding at the exam, and the biopsy revealed an adenocarcinoma with moderate area of differentiation. It was a G2. Blood exam showed an adequate organ function. The SIA was positive, 20 nanogram milliliter, and CT scan showed a thickening of left colon with proximal bowel dilatation, but no evidence of distal metastasis. The case has been discussed within the multidisciplinary colorectal group of our institution, and there was indication to surgery. In July 2020, the patient underwent a left hemicolectomy in video laparoscopy. And finally, the pathological report showed a colon adenocarcinoma with moderate area of differentiation, but also with poor area of differentiation. So it was a G2, G3. Finally, it was a PT4A and 0, so no lymph node involved out of 37 removed, with lymphatic and venous invasion and positive tumor budding. So it was a stage 2 with high-risk features according to TNM AJCC 8th edition. No surgical nor postoperative adverse event was reported. So the case has been discussed again within our multidisciplinary colorectal group, and indication to MSI status and DPD analysis have been performed. Immunohistochemistry have been performed, and MLH1 negativity, PMS2 negativity was found together with positivity in MSH2 and MSH6. So that was a pattern of MMR deficient case. Therefore, indication to RAS and BRAF status analysis was performed, and the patient was wild type according to next generation sequencing. So finally, MMR deficient, RAS BRAF wild type. DPD polymorphism analysis on blood showed no mutation, so the patient was wild type within 5 variants here listed. And in September 2020, patient arrived to our department for clinical evaluation. The patient had ECOG 0 according performance status, had adequate organ function, postoperative SIA was negative 0.8, and CT scan showed no evidence of distal metastasis. And cardiological assessment showed a good ejection fraction together with a right bundle branch block. However, no formal contraindication to fluoropyrimidine was performed by our cardiologist. So, discussion regarding postoperative treatment was performed, and the patient was strongly motivated to start an adjuvant treatment. And in consideration of the clinical pathological stage, so it was a stage 2 with high-risk features, deficient MMR, DPD wild type, the patient was proposed to receive postoperative treatment with fluoropyrimidine together with oxaliplatin. And after discussion of the advantages and the possible risk and side effect derived from the postoperative treatment, especially in terms of neuropathy and long-last toxicity, the patient accepted to receive adjuvant chemotherapy, and the regimen chosen was Xelox, so capecitabine plus oxaliplatin. So in September 2020, the patient started adjuvant chemotherapy according to Xelox regimen every 21 days. The patient started 54 days after surgery, so less than 8 weeks after surgery. He had a good performance status. He was overweight with a BMI of 29. During the first cycles, he had a neuropathy, grade 1, nausea, G2, fatigue, grade 2, who required a 1-dose level reduction. And after 3 months of treatment, so after 4 cycles of Xelox, prosecution with additional 3 months was discussed with our patient, and he was strongly motivated to complete total 8 cycles, so overall total 6 months of treatment. So overall, This treatment did not affect patient work life. Treatment was administered during COVID pandemic in a moment in which COVID vaccination were available. So mRNA COVID-19 vaccination were administered, and he received both first and second dose in February 2021. We performed genetic counseling and germinal testing have been requested. However, results are still pending. Patients have been educated to a healthy lifestyle, to quit smoking, to lose weight. And in March 2021, the patient had been addressed to follow-up care because he ended his postoperative treatment. And to date, no evidence of recurrent disease until May 2021. So I really thank you for your attention, and I hope that this case will contribute to a fruitful discussion with our panel of experts. Thank you.
So thank you, Dr. Cardone, for the clear presentation, and it's my pleasure to introduce Professor Tayeb, who is the head of gastroenterology and gastrointestinal oncology department at the Georges Pompidou European Hospital in Paris. So please, Julien, go ahead.
So good morning, everyone. Very happy to be with you for this ESMO webinar on adjuvant treatment for colorectal cancer. Thanks to Claudia for the very nice case she has presented that we are now going together to look at and to try to explain the different points of decision, and also looking at the recent ESMO guidelines on that topic. So here are my disclosures. So when we are dealing with adjuvant chemotherapy, we are talking about cure patients, and this is very important. We want to kill the residual tumor cells, also called the micrometastatic lesion, cells still present with a R0 surgery performed. In the future, CTC, ctDNA will be probably very important in that setting, but currently we are using statistics and trying to improve 3-year DFS and 5-year OS in our patients. What is relevant in this setting is very difficult to, I would say, to set up, because clearly we have a lot of colon cancer in the world. You know that we have approximately 1.8 million in the last registration we had, and it means that we will have hundreds of thousands of patients with stage 2 and 3 colon cancer resected every year. So if you save 1% of patient in addition to the previous treatment standards, you will save hundreds of thousands of life, and what is relevant here? Gain 1% may be not so clinically relevant in personalized medicine, but can be very relevant in terms of how many lives you are able to save. And this is also a very big challenge on how to judge what is clinically relevant in this setting. So from the case presented, we had a male 64-year-old with no big past medical history, something in the family with colon cancer and a left-sided colon lesion, CEA a bit elevated, and CT scan with no evidence of metastasis. So what is important in the new ESMO guidelines in what you need to have to really have the good workup before surgery for a colon cancer? You need complete colonoscopy. If it's not complete because the tumor is obstructive, you have to perform a new colonoscopy in the 6 months after the surgery first, but you also have before the surgery to try to have a CT colonography by imaging, by CT scan, which may help the surgeon to diagnose and remove another lesion in the colon that can occur in 5 to 10% of the case. You can also have a complete imaging with MRI abdominal. It's not mandatory initially, but if you have a doubt on a T4B, that may be challenging for the surgeon first, or if you have ambiguous lesion on the CT scan in the liver, MRI may help you. For the laboratory workup, it's quite easy. You need only a blood count, coagulation, liver function panel, kidney function panel, albumin, and CEA, which is a good marker for colorectal cancer. So the management of this case, surgical management in July with a left hemicolectomy, PT4B, grade 2-3, lymphatic and venous invasion, tumor budding, so many, I would say, high-risk factor for stage 2 patients. And the case was discussed, and they said that they want to have MMR status or MSI status, which is the same on the PYD analysis. So what is mandatory in the pathological report of a colon cancer resected? First, you have to have, of course, the location and the size of the tumor. But these are not the major factor for your prognostication. Pathological type and subtypes, you need a mucinous adenocarcinoma, for example. Tumor grade and differentiation that we had here. T-stage and end-stage, super important and the most important prognostic factors to date. The number of lymph node examined is also very important, and especially in stage 2, because we know that if you have less than 10 or 12, but generally 12 lymph node examined, you may misclassify your patient and make it a stage 2, but the patient is in real stage 3. Venous embolism, lymphatic invasion, perineural invasion are important also, as tumor deposit, which is a structure full of tumor cells without any residual lymph node component that you cannot distinguish from a lymph node fully invaded by the tumor or a local peritoneal carcinomatosis nodule. And these tumor deposits are very trendy these days because at ASCO 2019, 2020, and at ESMO last year, we had communication showing that we should count this tumor deposit as a new lymph node, and we may change the N1 to N2, for example, classification with this tumor deposit in the future. Resection margin, as in any cancer, we like generally 5 centimeter minimal from the last tumor cells to the section, and MSI status as asked in this particular case. Desirable but not completely mandatory today is tumor budding. Tumor budding is a few cells, less than 5, far away from the primary tumor that are seen generally close to the invasion front of the tumor. Isolated tumor cells are isolated cells in a lymph node that doesn't make the lymph node positive. It's less than 5 once again, it's generally 1 or 2 tumor cells, so the pathologist is not able to conclude that the lymph node is positive, but this has to be written in the report. And poorly differentiated cluster is a more novative pathological feature that may come in our pathological report in the future. So the problematic of adjuvant therapy is that you have to estimate the risk of recurrence, but you want also to diminish the risk of toxicity of your treatment and have an expected benefit that is relevant. In stage 2 patient, like in this case, the problem is that when you treat 100 patients with FOLFOX, for example, you will have maybe 3 to 5 patients cured because of the adjuvant chemotherapy, and 95 patients will receive the treatment for nothing. 80% of them are already cured by the surgeon, and 15% of them will relapse whatever you perform the chemotherapy. So the problem here is how to find the good population, and we really hope that in the future we will be able, with ctDNA and other approach, to better identify this patient at risk for recurrence, and in this patient, the one sensitive to chemotherapy and the one for which we need other kinds of therapeutic approach. Of course, we have also to be sure that we are not going to harm the patient in this very good prognostic disease in stage 2 patient. And I think that here, more than everywhere else, DPD is very important to be tested. DPD, you know, was tested since a few years in France. Now EMEA in 2020 asked it for all patients before 5FU treatment, and it is also recommended by ESMO. So just to have a brief reminder on 5FU toxicity, you know that I give you here the French numbers that went to make the DPD assessment mandatory before any 5FU infusion or capecitabine use. We estimate that we have approximately 100,000 patients treated with 5FU with all the different types of cancer in France everywhere, and that this leads to 500 deaths per year and 5,000 major toxicity, most of them being explained by partial or total deficiency in DPD. DPD, as you know, is the major enzyme to detoxify 5FU and to transform 5FU to inactive metabolites. And if you don't have this enzyme, or if it does not work well in your organism, you will accumulate the toxic compounds, metabolites of 5FU, and you will have more toxicity, and sometimes it can lead to death. There is 2 ways to test DPD: the phenotype, which is now mandatory in France, for example, and in some other countries, by testing uracemia. You have to test it in the 4 hours after the sample taken from the patient. You can see that the sensitivity and the specificity is good and the cost is very low, but it has to be implemented now in many laboratories that were not used to do it. You can also the genotyping. So the problem of the genotyping is that the specificity is excellent, but sensitivity is not fantastic. And for example, in France, we have a lot of patients coming from North Africa, Middle East Africa, and also from Asia. And the genotype that we can identify in Caucasian are not the same in Black and Asian population. So, for example, if you have a patient coming that is not Caucasian, these genotypes, sorry, are not completely accurate, and that's why we also prefer the phenotype in France. But both are accepted as good methods to test DPD in the patients. If we go now to MSI, that was also asked by the multidisciplinary board, MSI is very important in stage 2 because it confers a good prognostic to your patient. You can see here the first publication from Jan Park a very long time ago in Gut, showing that when you have a T3 and 0 MSI patient, the risk of relapse is less than 10% at 10 years, and this was confirmed by the quasar post-hoc analysis on MMR deficient and proficient patient, showing that you have 27 relapse in the proficient patient, and in the deficient patient only 10%. So really MSI is a good prognostic factor in stage 2. It's more complex in stage 3, but in stage 2 it's a good prognostic factor that may help you to decide not to perform any adjuvant chemotherapy in some of these patients. In stage 3, this is the publication we've done with the Axon database and Romain Cohen this year, and you can see that here we have a very small benefit of 5FU in MSI patient, but a very good benefit of oxaliplatin in MSI patient, and that if you have an MSI stage 3 patient, and probably also stage 2, but we don't have enough data to state that on stage 2, you need not to do fluoropyrimidine alone, but also an oxaliplatin-based schedule. So the patient was tested for MSI. In the case, he was MLH1 negative and PMS2 negative, so deficient MMR. And the patient MSI high here is quite, I would say that you have to focus on what antibodies are being used, what protein are expressed. If you have, for example, a loss isolated of PMS2, be aware that this antibody is not so good and you have to control your status by molecular biology. When you have both MLH1 and PMS2 negative, you're quite confident in the immunohistochemistry results. So they also indicated in this case RAS and BRAF, and the patient was RAS and BRAF wild type. RAS and BRAF are prognostic. We have published a pooled analysis with NO147 and PTAC8 trials with Frank Sinicrop showing that they are a really good prognostic factor for stage 3. For stage 2, it's less clear, and they are generally not mandatory because it doesn't help you to tailor the adjuvant treatment or the surveillance of your patient today. However, when you have an MSI patient, BRAF may help to determine if it is a Lynch syndrome or more a sporadic case, so it may be interesting to have the BRAF status of such a patient. So the patient in Italy was tested for DPYD polymorphism. He was not mutated, and there is also a good performance status. CA was normal after the surgery. CT scan still no evidence of distant metastasis. Electrocardiogram and cardiological evaluation was good. So globally, no formal contraindication in this patient to fluoropyrimidine. So what are the ESMO recommendations for stage 2 colon cancer patient that were resected? We moved from a high risk and low risk group to 3 groups now. The first one is the low risk group. It means a patient with a stage 2 disease with no pathological risk factor. In this patient, if they are MSI or MSS, you don't have to perform any chemotherapy. At the opposite, we got the high risk group, which is patient with a PT4 tumor, less than 12 lymph node examined, and in this case, more than one intermediate risk factor that we are going to list later. So if you have multiple intermediate risk factor, less than 12 lymph node or a PT4 tumor, you move to FOLFOX 6 months or CAPOX 3 months. From IDEA, we had a comparison of CAPOX 3 months and 6 months, showing that it's more or less the same. And here you can have as an option also FOLFOX 6 months, depending on what is your trust on IDEA results that were difficult to interpret. If the patient is not low risk or high risk, but has several intermediate risk factor, but generally only one or two of them: lymphatic invasion, perineural invasion, vascular invasion, histological grade 3, tumor obstruction, or preoperative CA quite elevated. Most of these factors were present in the current case, but the patient was T4B here, so it's not an intermediate, it's a high-risk group. But if you have one of these factors, then you test the MSI. In MSI high patient, due to the very good T3 and 0 patient prognosis that I showed you, no adjuvant chemotherapy. If the patient is MSS, let's move to capecitabine, and if it's not possible, you can go to a digrammon regimen. So here is the most important testing for MSI. But I think that in daily practice, of course, you will ask MSI to all your patients, not to wait for an additional test. Here are the results of stage 2 patient in IDEA, and you can see that if FOLFOX 6 months gives the best 5-year DFS rates, 3 months of CAPOX or 6 months of CAPOX are really similar as we observed for stage 3. For stage 3 disease, the new thing is that from IDEA, we learned that high risk and low risk stage 3 do not bear the same prognosis at all. We know that high risk stage 3 are defined by PT4 and or N2 tumors. MSI or MSS for stage 3, you don't care about the MSI status. And low risk is PT1 to 3 tumor N1. So the conclusion were that for the high risk tumor, you go to FOLFOX 6 months or CAPOX 6 months, but we are going to publish soon that CAPOX 6 months has to be stopped more often than FOLFOX 6 months. It's a bit more difficult to get the full treatment in the patients. And for low risk patient, you have to go to CAPOX 3 months, which is really more relevant for the patient, less toxic, with no residual neuropathy, and very safe in low risk stage 3 patients. So the patient in the clinical case was strongly motivated. He went to CAPOX for 3 months in this case, and he's really performing well and going well after, with no evidence of disease later on. What about the surveillance? Surveillance is not the same in all European countries, so we had to determine ranges during these guidelines. It was not possible to ask for maximum surveillance to every country where it is not feasible. So that's why you have CEA assessment 3 to 6 months, CT scan 6 to 12 months, and colonoscopy every 3 to 5 years, up to 3 years after the surgery. And from 3 to 5 years after the surgery, you slow the surveillance. Then CA can be done every 6 to 12 months, CT scan every 12 months, colonoscopy still 3 to 5 years, depending on the finding. If you have polyps of more than 1 centimeter or multiple polyps, you have to continue the surveillance every 3 years. If you have a clean colonoscopy, you can move to 5 years. So in the case of Claudia, you can see that treatment did not affect patient work life. He was vaccinated for COVID. Genetic counseling was performed because of the MSI status of the patient. And education, healthy lifestyle, quit smoking, lose weight was recommended. In March 2021, the patient was addressed for follow-up. To date, no evidence of recurrence in May 2021. So a very good outcome for this patient. So to conclude, I would say that adjuvant therapy is challenging. We really have not to harm the patient, but to try to save as many lives as we can. Selecting the good patient for the future is really a priority, but today only MSI allows not to perform chemotherapy in some stage 2 patients. After IDEA, CAPOX 3 months for low risk and FOLFOX 6 months for high risk is the recommended treatment. Stage 2 can be followed up for low risk patient. We have now 3 groups for these. Receive adjuvant fluoropyrimidine alone, either orally or IV if not possible to have capecitabine in this patient, or FOLFOX CAPOX for high-risk patient. Neoadjuvant is an option. I didn't talk about that during my talk here because it was not awarded in the ESMO guidelines, but we have the Foxtrot trial with many results that will come in the future. And ctDNA raised probably major hopes in this situation. Clinical trials are ongoing, and in a few years, we will have all the answers to this question. Thank you very much for your attention.
Thank you, Julien, for the critical analysis. And now it's the time for Dr. Lipositz, who is a senior oncologist at Wilson Hospital Trust in Denmark and also PH Fellows, Department of Oncology at the University of Southern Denmark. So please, Gabor, go ahead.
Good afternoon, everyone. My name is Gabor Lipositz, and on behalf of the ESMO Practicing Oncologist Working Group, I'm going to share my thoughts about guideline implementation in everyday clinical practice related to stage 2 colon cancer. My disclosures. During my talk, I'm going to answer the following key questions regarding guideline implementation in the clinical practice. Are data from randomized controlled trials applicable to the clinical practice? Are patients included in clinical trials representative for the general population? With other words, do we see the same benefit of the treatment in the real-world setting? And finally, Are the recommendations from the ESMO clinical practice guideline implementable in the community setting? The most important question is whether patients included in clinical trials are representative for the general population oncologists are facing in their everyday clinical practice. Here you can see colon cancer incidence by age group from the United Kingdom. And we need to remember that cancer is related to aging, and aging is the strongest non-modifiable risk factor for developing cancer. The median age for colon cancer diagnosis is about 72 years, and both incidence and mortality peak in adults older than 75 years. However, these patients are rarely included and clearly underrepresented in clinical trials. And this has a particular importance considering that the number of older adults with cancer is going to double in the next 15 years. We do know that in the general population, the median age at colon cancer diagnosis is about 70 years. Patients are often presented with comorbidities and impaired organ function, and ECOG performance status greater than 1 is quite common. So let's have a look at patient characteristics in clinical trials included in the IDEA project. The IDEA project included over 3,200 patients with stage 2 colon cancer from 4 clinical trials. In the TOSCA trial, the median age was 63 years, and over 95% of the patients had ECOG performance 0. In the ACHIEVE-2 trial, the median age was slightly higher, 66 years, but again, 96% of the patients had ECOG performance 0. In the other 2 trials, age distribution was similar, and patients with ECOG performance 0 overrepresented. Especially thought-provoking that only 1 patient of 3,200 had an ECOG performance status 2. So we can conclude that in the IDEA project, the clinical trial population doesn't represent the majority of patients seen in clinical practice. Included patients were younger and fit, older vulnerable patients were underrepresented, and we know as well that in real-world setting, in the general population, patients probably experience more toxicity and less benefit from the treatment than patients included in clinical trials. How can we optimize the care in underrepresented populations? Older patients are frequently treated based on evidence obtained in young and healthy cohorts. So we really need randomized controlled trials dedicated to older and vulnerable patients. The concept of patient-centered care should be included in daily clinical practice. And patient stratification should occur based on the biological age of the patient rather than chronological age and ECOG performance status. And this can be done by the widespread implementation of geriatric screening and assessment. When we are discussing adjuvant chemotherapy in stage 2 colon cancer, we need to focus on the biological age of the patient, and one should always assess the life expectancy. The competing risk of non-cancer death has particular importance in this setting in terms of avoiding overtreatment, which is quite common in stage 2 colon cancer. And we should remember, we should always listen to our patients, to their preferences, and actively involve them in decision-making process. So oncologists tend to focus on tumor characteristics like TNM stage, histology, molecular alterations in the tumor, and make decisions based on easily accessible clinical factors like ECOG performance status and chronological age. This approach is frequently applied at multidisciplinary tumor board meetings and might be feasible in young and healthy patients. However, the majority of patients with cancer are older and presented with comorbidities and impairments. In these patients, patient-centered approach is desired, which is also assessing comprehensively tumor characteristics, while it is focusing on the in-depth assessment of patient characteristics which cannot be revealed by past medical history or physical examination. Such factors are fatigue, depression, cognitive function, social function, sarcopenia, and geriatric syndromes. Patient-centered care has shown several benefits for patients also in randomized controlled trials. The ESMO Clinical Practice Guideline Stage 2 colon cancer is easily applicable to the clinical practice. And I would like to highlight some take-home messages for the practicing oncologist considering prognosis. MSI status is the most validated prognostic factor. Immunoscore, gene signatures, circulating tumor DNA are not ready for prime time yet. Only grade 3 tumor burden is associated with increased risk for recurrence and mortality. RAS and BRAF status are not recommended for risk assessment in the adjuvant setting. And some considerations regarding the adjuvant treatment. Here we should always balance the risk of toxicities and benefit. As I mentioned earlier, we should focus on the biological age and the life expectancy of the patient. The risk of toxicities should be also discussed with patients and caregivers. Preferring capecitabine and Capox over infusion regimens is reasonable based on efficacy data, and these regimens are also less resource demanding and absolutely applicable also in low and middle income countries. We should keep in mind that the sooner adjuvant treatment is administered, the higher is the benefit. And we should always ask our patients about their preferences and actively involve them in decision-making process. So finally, I would show you two slightly different approaches. One of those has been presented earlier today by Professor Tayeb, the ESMO Clinical Practice Guideline, and I will talk briefly about the more practical, more patient-centered approach published by Dr. Rebuzzi and Professor Sobrero. I really do like this practical approach because it's starting the assessment with competing risk for non-cancer death. And if you look at the treatment options, so 6 months of Capox is no longer considered as treatment option in stage 2 colon cancer. So these were my thoughts about guideline implementation in clinical practice related to stage 2 colon cancer. Thank you very much for your attention.
So the main point for discussion from these clinical cases is the decision to perform chemo in this PT4 MSI patient. So there are a lot of discussion about the benefit of oxaliplatin, and a lot of discussion about 3 months of Capox versus 6 months. So this is something that has been already addressed by Julien, but Julien, can you address more this and explain why it was a right decision to perform 6 months of Capox in this patient?
Compared to stage 3. We don't have a lot of trials dedicated to stage 2. The magnitude of the benefit of chemo is lower in stage 2. So I would say that we are also reasoning and recommending on multiple comparison, cross-trial comparison, cross-Armstrong comparisons also in different trials. So I would say that what is important is that really in this case, it was a T4B with other clinical factor of poor prognosis. These patients are known to have a worse prognosis than stage 3 patients with T3 and 1 tumors. So I think there is no doubt that this patient needed a 5-FU and oxaliplatin-based regimen. But in general, it is true that the only data of good quality we have are the one of Mosaic that are showing a benefit non-significant in high-risk stage 2 only, with a magnitude of the benefit which is around the stage 3, 5%, but not powered for the statistical analysis and thus not significant.
Okay, thank you. Another questions, a couple of questions are regarding to the elderly population. Okay, so they asked for patient the benefit of oxaliplatin in patient with more than 70 years. And another question came for Dr. Cardone, and saying that if this a patient with a heart problem, would you recommend to use also the oxaliplatin to this kind of patient?
Actually, it is important to evaluate comorbidity of the patient and to try to weight toxicity and the possible benefit. This case in this patient, we informed patient of possible toxicity, especially in terms of neuropathy and possible long-lasting neuropathy. The patient was quite young, so the benefit was possibly bigger than toxicity. Obviously, in case of elderly patient, we have to consider general comorbidity, especially for use of oxaliplatin.
Okay, thank you, Claudia. Gabor, a question for you. In case they asked, you didn't ask, in case of DPI deficiency, what are the adjuvant options for the patient with stage 3 or stage 2 high-risk colon cancer?
It's a really good question. If the patient has DPD deficiency, so we need to balance the toxicity. And this patient had actually a really good prognosis. So in this case, I wouldn't consider adjuvant chemotherapy.
Okay, excellent. So another question for the gene signature expression as a prognostic in stage 2. Julien, what is your opinion on this topic?
Yeah, I think we have big hopes with ctDNA and possibly with immunoscore. This has to be re-evaluated in stage 2. I think, unfortunately, gene signature are not discriminant enough to help the clinician. It will help a lot the insurance company to estimate the risk of the patient and the money, the price of the insurance, but not help the clinician today for clinical decision. We can have a nomogram in the future, including some genomic signature that may help, but this is not ready for practice today. So this is quite clear. I just want to comment something for the elderly, to say that the elderly, we need to have oncogeriatric trials in the adjuvant setting. They are ongoing in different countries in Europe. And the results will come comparing 5FU versus observation or FOLFOX versus 5FU. These questions are very important because in my hospital, the geriatrician wants to kill me when I say he is too old for an adjuvant therapy. They say that it is racism. So we also have to treat them good, and I think we have to have dedicated trial for these patients.
In fact, regarding to the elderly population, there was also another question about a problem, a patient with a stroke, with a previous stroke. Do you recommend an adjuvant treatment, elderly patient with a stroke?
Well, it depends on life expectancy and other comorbidities as well. So I think in this case, we should discuss with the patients what are the potential benefits of the treatment, what are the risks of the treatment, and we should make a shared decision with the patient and relatives.
And Gabor, come to you again. There was a question about the use of predictive role of immunoscore. You have already addressed it during your talk, but maybe it's important to boost again this. Can you give us a comment on this topic, please?
So according to ESMO guidelines, it's not ready for prime time. So we don't use it routinely now, but maybe it's the future.
Okay, it's like ctDNA, just like has been already discussed by Julien. So there is a very nasty question because there's a question about a pregnant woman. In case of chemo indication with patient with pregnant during the first and second term, which drug should you avoid or contraindicate? Or I'm wondering if we will use a chemotherapy in this lady. So what do you think, Julien? What do you do?
Oh, yeah, we have data on that. Now, I think that the first child born with an oxaliplatin adjuvant treatment was 14 years ago, and he's going perfectly well. So generally, our chemotherapy, and it's the same for FOLFIRI, by the way, but FOLFOX or FOLFIRI, I don't know for the triplet. I don't have any data on that, but for FOLFOX or FOLFIRI, they kill the baby in the first 3 months generally, but if it's going well, the babies are going well. We don't have 20 years of follow-up. We don't have a lot of patients. I have found a few years ago for a talk approximately 10 case reports, but I think that currently there is no teratogenicity, and that if the lady is pregnant and wasn't aware and the baby is still there after 3 months, she can keep the baby, and we may maybe lighten after 3 months or stop at 3 months the chemotherapy in this case.
Thank you very much. Personally, I do not have any experience on this. So another questions about the tumor budding, because tumor budding is a real, maybe promising new practical tool, not to assess the risk in stage 2. Which is your opinion about tumor budding?
I can just tell you that I think this is a more and more important pathological feature. We have analyzed also in IDEA France more than 1,300 patients for tumor budding in stage 3, and it is also an independent prognostic factor, completely different from stage, and also because we had immunoscore, it's also an additive prognostic factor on immunoscore and on ctDNA, because all that was done. So this will be communicated at ESMO by one of your Italian colleagues that came for a year in my unit.
Okay, thank you. Claudia, a question for you. If this patient with MSI would have a T3 and 0 tumor, what adjuvant regimen would you have to choose?
Actually, we should consider the other high-risk feature. So if the patient had V1 and 1, so perineural or vascular, together with poor grade differentiation, with a stable and a MSS status, I would have considered at least capecitabine. In case of MSI, the indication for adjuvant would have been a little bit more tricky, but however, I would have discussed it with the patient, always according to his willingness to consider possible long-lasting neuropathy, at least 3 months of Xelox. Do you have any other idea on this topic, Julien?
We have here again a very small literature on the topic for stage 2 MSI, except the 2 or 3 ones I presented to you. I missed one big paper, and we don't have especially a good decipheration on T4B, T4A, multiple versus 1 intermediate prognostic factor. What is sure is that if we do chemotherapy, we don't do capecitabine or 5-FU alone, as you said. We need to put something with oxaliplatin because it doesn't seem to be harmful as compared of what was said by Dan Sargent 10 years ago, but it's not beneficial. So if we do chemotherapy, we do a doublet. And I would say that I would need for MSI to have many risk factor to do the chemotherapy, or T4 or less than 12 net node. But I will never treat an MSI patient in the intermediate group or in the low risk group, of course.
Okay, thanks. Another question, Gabor, for you. And the question is, in patient with R1 or 2 resection, is any recommendation on close surveillance, or you should treat him like a metastatic patient?
Well, it's a really good question. We know that about half of patients resected R1 or microscopically residual disease won't get any relapse. So I think one should consider adjuvant therapy, but thereafter maybe closer surveillance with imaging can be performed. But we don't have any good data on it. So it's a really tricky question. Thank you.
Yes. So another question for the 3 experts. There is a patient with stage 2 intermediate risk, BRAF mutated, MSS, positive ctDNA post-surgery. Would you recommend research or clinical practice therapy? Is a stage 2, BRAF, MSS, positive ctDNA.
Encorafenib and cetuximab for 3 months. No, I'm joking. No, I think we are going to treat BRAF and MSI patients different adjuvantly or neoadjuvantly in the future. This is only the message I wanted to say. But in this specific case, I think we have to stick to the guidelines, because even if BRAF has been shown to increase of 10% the recurrence rate in stage 3, we don't have here again a lot of data for stage 2. And I will not modify my attitude because the patient is BRAF mutant in the adjuvant setting today. but clinical trials would be good.
Claudia?
Yeah, I do agree. Maybe I will consider the other high-risk feature in order to consider an adjuvant treatment, but however, I will stick to guideline, or if available, a clinical trial, rolling in a clinical trial.
And Gabor, finally?
Yes, I agree. A clinical trial would best for the patient, but if not clinical trial, so maybe 3 months of CAPOX.
Okay, so just another question for Claudia, because it was related to the clinical case. And the question is, could be your patient a Lynch syndrome because it's a MLH and BRAF negative? I am wrong? This was the question.
Well,